Today, I'd like to share with you a TAVI case that we have just completed. Our patient is an 83-year-old female. She's a patient who suffered from severe shortness of breath. She'd been examined for 7 or 8 years for this, but it was thought to be a lung problem causing the shortness of breath. 15 days ago, she came to us with a condition we call pulmonary edema. In other words, fluid buildup in the lungs causing severe shortness of breath and even brief respiratory arrest. When we took her to the ICU and examined her, we saw the aortic valve was severely narrowed and decided this was responsible for her condition. And following that, we performed a series of tests on the patient. We held a heart council regarding intervention for the severe aortic stenosis. We discussed the patient with our surgical colleagues and decided she was a high-risk individual due to her age and other comorbidities. In addition, she was a female patient with very low weight, meaning a very low body mass index. Consequently, she also had a quite small ventricle. Ultimately, as the heart team, we decided to perform a TAVI procedure on the patient. In our preliminary preparations, we performed a CT scan to determine the suitability of the entry sites in the groin area. We also evaluated the heart valve with the guidance of the CT scan. Based on the CT results, we decided on the valve size, specifically which size valve we needed to use. And on the day of the procedure, we took the patient to the angio lab. This is a procedure performed without any general anesthesia and without opening the patient's chest. We began by entering the artery in the groin and the vein to use a temporary pacemaker to run the heart while placing the valve. I'll show you the stages, of course, but here we have a pacemaker to run the heart, or rather, to speed it up. We passed through the severely narrowed valve with the help of a wire. Right here you can see our valve that hasn't been placed yet. We'll advance it in a moment and then we'll place our valve. By increasing the heart rate with the temporary pacemaker, we placed the balloon-mounted valve into the aortic region. When we took the images, we saw angiographically that the valve worked perfectly with no leaks, performing its functions. We also visualized it with the help of an echocardiogram. Seeing no problems, we finished by closing the groin entry site with devices we call closure devices. We moved our patient to the intensive care unit after the procedure. After 1 night in the ICU and 1 night in a regular room, she was discharged in good health. We discharged our 83-year-old patient with a low BMI and other comorbidities from the hospital in a very short time. Therefore, the TAVI procedure stands out as a method that is safely performed in patients with high surgical risk.